Okay, with that, it's the top of the hour, so I think we'll get started. Welcome everyone to ASJ GEMS Global Educational Meetings. I'm your moderator, Phaedra Kress. I'm so excited today to be joined by Dr. Marc Pacifico. He'll be presenting on breast implant malposition, controlling the external pocket. And Dr. Pacifico is one of the leading plastic surgeons in the UK and the president of BAAPS, the British Association of Aesthetic Plastic Surgeons. He regularly lectures nationally and internationally to colleagues and is known in particular for his breast and facial plastic surgery. He's a member of the Aesthetic Society, ISAPS, BAPS, the Royal College of Surgeons of England, and the General Medical Council. He's also one of our esteemed international editors for the Aesthetic Surgery Journal. Welcome, Dr. Pacifico.
Thanks so much, Phaedra. Thanks for inviting me today, and thank you all for tuning in. As Phaedra said, I'm going to talk about implant malposition and analyze it and talk about some of the challenges and potential solutions to those challenges. So the first question with any talk is, why is this important? And really, it's because of this. None of us want to be in this sort of situation. We can see someone with significant malposition, lots of problems going on, a very unaesthetic and also functionally problematic breast situation. So in today's GEMS, I thought I'd split the talk into three different sections. First of all, I'd like to present a section on classifying implant malposition, something that isn't really talked about or thought about too much. Secondly, we need to think about how we prevent it in the first place, because clearly, like anything we do, prevention is better than treatment. And if we get it right first time, we're in a much better position than trying to treat something that is problematic. And then I want to go on to controlling the malposition, internal but principally external controls, and what we can do, and give you some, what I hope are some innovative thoughts and ideas about this. So I'm very fortunate that we had our classification of breast implant malposition published very recently in the Aesthetic Surgery Journal. And I wanted to talk to you about this because what I hope we've done is we've, for the first time, provided a useful tool that we're all going to be able to use, not only for communication and discussing implant malposition, but also to help with decision-making for implant malposition. So we know from the literature that there's, in some cases, a very high malposition rate. Some studies quote 11%, and there are many interchangeable descriptive terms. And what struck us was that actually is no uniform classification system. So our aim was really to develop something simple, something we could use in the clinic, in the hospital, that is reproducible, and it can be used in all situations of implant malposition. So the purpose was several-fold. It was something that's pragmatic, describing the degree of implant malposition, and we wanted to align it with something simple like the Baker-Capcom classification system or the Regnote-TOSIS classification system. And to be a useful classification system, we also wanted this to help guide potential decision-making, when to intervene surgically. And of course, with any useful classification system, it also provides an aid to discussion and communication, both between surgeon and patient, but between surgeons themselves. So our study composed of a retrospective review of 430 patient charts, 201 of which we found had malposition, and we had some very strict inclusion criteria that you can read about in the paper, which 100 of these fulfilled. So we analyzed clinical photographs initially and used a calibration method that Eric Swanson actually described in one of his papers. And through that, we analyzed all of those patients, 189 breasts with a mean age of 46. And we looked at the distance from the ideal position of the breast footprint and calculated how the degree of malposition in different patients. And then we correlated that degree of malposition and surgical decision-making to establish whether there was a link between the severity of the malposition and the surgical intervention. We then took our draft classification system at that time and then applied it to a prospective cohort to see if it was a realistic, usable, and pragmatic system in the day-to-day setting. And I'll describe to you what we came up with. So in very simple terms, we have three grades of malposition, grade 1 through 3. Grade 1 malposition is less than a centimeter in any orientation. Grade 2 is between 1 and 3 centimeters of malposition, and grade 3 is a malpositioned implant greater than 3 centimeters. And you can see in the illustration here, a figurative illustration of a grade 3 malposition in the different vectors. So we chose to use superior and inferior as opposed to cranial and caudal because of the potential confusion with the abbreviated letters C and C. So superior, inferior, medial, and lateral. And it's very easy to apply. So for example, a right breast with a lateral malposition of 2 centimeters and a left breast with a lateral malposition of 2.5 centimeters, that would be on the right side an L2 or a lateral grade 2, and on the left side also an L2 lateral grade 2 because they fall within that bracket. A right breast with an inferior malposition of 4 centimeters and lateral malposition of 2 centimeters, the right breast would be an I3 grade 3 or an L2 grade 2. So I just want to run through with you a short video of using this in practice. Let me just see if that video will play for us.
What I'm going to do to assess that lateral malposition, I'm going to just lateralize her breast with some manual palpation and draw where the implant currently comes in. Then I'm going to medialize the implant to where I feel the lateral border of the breast ought to be, which is around here. And that gives us a line over here where I want the ideal lateral position of the implant to be. We can measure this distance. This distance is measured at 4.5 centimeters, which is a grade 3 lateral malposition. So this patient would be classified as a right breast grade 3 lateral malposition.
So you can see it's a very straightforward, pragmatic classification system that we can use. So what did we find? Our combined retrospective and prospective cohort was 242 breasts. We also did a little mini inter-observer variability study to check that between the authors and also between some clinicians not involved in the study, this was applicable. And actually we found an inter-observer variability of less than 10%. And if you compare that with the Baker classification systems, where there can be a nearly 50% disagreement between observers, I think we have done very well up front. Most malposition, predictably, was lateral and inferior. 78% of the lateral malposition was grade 2 and L2, and 16% grade 3. And nearly 2/3 of the inferior malposition was grade 2, with a third being grade 3. So some clinical examples, a patient on the left of the screen, her right breast shows a grade 1 or an I1, inferior 1 malposition versus an I3 malposition on the patient on the right breast. This patient has bilateral I3 malposition, very significant caudal malposition or inferior malposition. And here, based on the measurements, this patient's right breast has an L3 and her left breast has an L2, whereas both of this patient's breast also has an L2 on the right and an L3 on the left. And both of these patients have, this patient's sides or lateral malposition is an L3. And that's done by that displacement of the implant. So how is this relevant and what are the outcomes? Well, what we found was every patient with a grade 3 malposition underwent revision surgery with malposition cited as the main reason for electing to undergo surgery. Not a single grade 1 malposition patient underwent revision surgery with malposition cited as a sole indication. It might have been one of a number of reasons, but it wasn't the main indication and certainly was never the sole indication. And predictably, I guess, the grade 2 patients demonstrated a variation in decision-making. So what we took out of this is some recommendations, and we've certainly applied this to our clinical practice and found it very helpful to talk to patients with their decision-making about whether to go ahead, and actually our decision-making as well. So if someone has a grade 1, a minor degree of malposition, we would advise against any surgical intervention to address the malposition. It's not worth it at that stage, at that minor stage. With the grade 2 patients, the decision to surgically address the implant malposition is very much dependent on that discussion of the balance of pros and cons in that individual patient. Whereas those who present with a grade 3 malposition, we felt that was a situation in which we could relatively objectively talk about intervening specifically to address the malposition, whether or not there were other issues with the breast. So we've talked about classifying it, but we now need to think about how we try and prevent this happening in the first place. So how can it be prevented? Well, I think there are 3 groups we can think about. We can think about decision-making with regard to the implants, adjunctive measures we might be able to take, and then crucially, and something I want to spend a bit of time on, is decisions about the inframammary fold, because I think that's where a lot of the problems might start. So no question that if you remember Hooke's law from our physics classes in school, the heavier the implants, the more force, the more stretch, and the greater the chance of malposition. And our patients are going to have a variety of genetic backgrounds of soft tissue quality, and the ability of different individuals to support the weight of a given implant, whether that's inferiorly or laterally, is going to vary from multiple factors. And in addition, we've got to bear in mind the variation in morphology of chest wall, slope of the rib cage, all sorts of other issues. So the ability of our soft tissue, particularly inframammary folds, to support the weight of a given implant is key. So with our implant decisions, we know, and the literature supports very clearly, that there is a higher rate of malposition in smooth implants compared with textured implants. And I'm very aware there are different geographical cultures and preferences for different surface implants, but this is an inescapable fact. And it's come to be almost evidenced by the fact that where there are some shaped smooth implants, they have now been produced with tabs to try and suture the implant to prevent any malposition or malrotation. We know that on the other end of the spectrum, the most textured implants are polyurethane implants, so those are going to be the most stable. And then we've got microtextured implants that are somewhere in between. And without doubt, those are the most commonly used, certainly in Europe and many other territories. And most anatomical implants are going to have a form of microtexturing, or if not, potentially polyurethane implants. And then there are adjunctive methods. So the different things we could use are really mesh related, whether that's P4HB, Tiger mesh, tie loop, and many other alternatives that can be used as either a hammock. It can be put in primarily or secondarily. It can be used as a ravioli, wrapping the implants technique, much like adopted from a breast reconstruction prepectoral approach. And that's, as I said, can be used in primary cases or secondary cases. So then, in summary about implant decisions, we need to accept there's no perfect implant there. And decision-making is multifactorial, and we can't ignore the patient. And the patient has certain desires, and we as surgeons, I think, have certain duties to analyze and educate the patients as to if we think certain decision-making will be inappropriate, whether it's in the short or medium or long term. And I don't think we should be making any decisions on implants or techniques on a single issue. We shouldn't make it just on implant malposition, just as we shouldn't be making an implant decision purely on risk of ALCL or purely on risk of capsular contracture. I think everything needs to be put in perspective for a given patient, and everything needs to be considered with that patient as to the trade-offs, because that's what we're always dealing with, of course. So there's that compromise that's always required. And I think if we accept that and bear in mind where we've got higher risks, such as using a large, heavy, smooth implant, we can then think about whether or not, in certain cases, we need to mitigate that risk. So I want to spend a bit more time on malposition-related decisions related to the inframammary fold, because I think that's where it falls foul. And I really want to spend some time thinking about planning and then just reviewing, I think, what is an excellent paper from some Australian colleagues. So when we're thinking about our planning of any implant surgery, we're thinking about the position of the inframammary crease or fold, or thinking about the nipple position, considering whether that lower pole skin is going to expand or we need to recruit some upper thoracic skin. And we've got to consider the height and width, but particularly the height of the implant, the ideal future position of the inframammary crease, and the nuance, important consideration of crease or fold asymmetry and how we might either respect it or try and adjust it. And we want to avoid, of course, those risks of caudal or inferior malposition that might result in double bubbles or bottoming out, it's either what I'd call an iatrogenic double bubble, and that's poor planning and incorrect decision-making, or a post-operative inferior malposition that's resulted in it. And a bottoming out, slightly different from double bubble, is where there's total loss of support of the inframammary fold and the implant really has shifted down and expanded below the inframammary fold. If there's one message from this whole talk I would suggest you take away, is this. If the inframammary fold is well formed, such as in this background schematic, do not lower it. I think you are guaranteed a double bubble. And this was really borne out in the paper by Craig Late that was published in 2021, where he and colleagues looked at their outcomes of breast augmentation, looked at double bubbles, and looked to see if there was a way of correlating the risk of double bubble formation and other similar issues with the morphology of the breast, and particularly the breast crease. And what they looked at is they looked at their patients with their arms down by their sides and their arms behind their head, and they recognized that the more well-formed the inframammary fold was with their arms above their head, the higher the risk of double bubble forming, i.e., the more established the fold, the higher the risk of double bubble. And they classified their folds from F0 through to F3 or F3A and B, which was visible folds with arm elevation. And they found that their double bubbles really only occurred in the F3 folds, with the recommendation that in those situations, you need to ideally respect the fold. And in other situations where you might lower it, you need to consider whether you need to reconstruct that and how you reconstruct that. So when that applies to our decision-making, the F0 to F2 fold can kind of be ignored in planning, like in the photograph of a patient I've operated on in the screen now. However, of course, a potential complication there is that inferior or caudal malposition to result in a bottoming out. They're not going to get a double bubble because there's no existing established fold to create that memory of the original fold. And I think these are cases you've really got to think about reinforcement to the inframammary fold, especially with those large, heavy, smooth implants, because these patients often, with their F0 folds particularly, will have quite delicate soft tissues and they are at high risk of malposition. And you don't want a situation like I had in this patient where a smooth implant has bottomed out. She's not got double bubbles. She had an F1 fold beforehand, but you can see it's just expanded and it's just sitting far too low compared with her left breast. F1 fold lowering, we can, as I said, almost ignore the fold. You can look at the particular implant size and implant choice, see where the nipple is going to be centered in future. And if you need to lower that, then you can almost at will. And you can create a very nice lower pole curvature with no hint of the existing memory of the inframammary crease, i.e. no double bubble in that situation. With an F2 breast, which is halfway there, it's not quite the F3, but it's certainly not the F0 or F1, you've got to be a little bit more careful. So in this patient, you can see she's got a very short nipple to inframammary crease distance. I needed to lower the fold because even if I'd respected that fold, she would have had far too short a distance and nipples pointing far too low. She's a composite augmentation. And also you've got to bear in mind that the more you lower the fold, you might have the subsequent knock-on effect of unintended shortening of the torso. So here you can see her results post-op, and she's got an acceptable result with lowering the fold and a nice lower pole curvature. The F3 decision-making then is almost taken out of our hands. And as I said, if it's well-defined fold, don't lower it or lower it very minimally and respect the anatomical footprint, particularly the breast height, because one risk is if you're respecting the fold and there's a short height breast, your implant sits too high. And this is certainly where in Europe, maybe perhaps less used in the US, a short height anatomical implant really comes into its own. So if you try and lower the fold in an F3 situation, you're almost guaranteed a double bubble. And the double bubble will occur if the implant that's put in the right place dislocates inferiorly. So here's a patient who's a very easy decision-making. You don't need to lower the fold. She's got an F3 fold and she's got a very nice aesthetic result afterwards. where you've got an F3 fold with good proportions. Otherwise, you can use an implant of your choice. I've used an anatomical implant to try and effect a small help with the ptosis that she has, and no need to do anything. And as I said, these can be almost easy decisions because the decision's taken out of our hands. And I think this is where the breasts can get quite tricky, where there's a short height breast. You've got very limited options. And my preference is to use a low height anatomical implant. If you consider lowering the fold, you've got to be very careful. I've lowered it a tiny bit on her left to try and improve her fold symmetry. And the alternative might be a smooth round implant, anticipating some lower pole stretch. Whether that's predictable or not may depend on your choice of implant and your experience too. I think she's got an acceptable result, respecting the footprint of the breast she has without takeoff being too high on her chest wall and maintaining the fold in its natural, very established position. If we are going to have to lower the fold when there is quite an established fold, such as in a case like this, and which is something we have to do frequently when we're having more tuberous breasts, I think the danger is when you lower it too much. I think a highly cohesive anatomical implant is really useful here. That high cohesivity and that off-center lower point of maximal projection does what the implant can to help give some pressure. Radial scoring as appropriate, and I quite like to suture reinforce the inframammary crease, even putting some internal sutures beyond the scar to really try and almost use the implant as a fulcrum for the breast to hinge over the implant to try and physically force away the evidence of the fold. And it might be that fat grafting is used. Personally, I would do that as a second stage, because once the breast has internally been radial scored, there is really no recipient site that is reliably vascularized for fat. So what about the conundrum with fold asymmetry? You can either respect the fold asymmetry, you can try and level the folds, or you can sort of hedge somewhere in between. And I want to show you a few examples. Some I've got right, some I've got wrong. So here, she's got some modest fold asymmetry. I've lowered her higher left fold, and incidentally, or you all have probably noticed and seen over examining many breasts over our careers, is that virtually every breast is higher with a higher fold on the left side. I have not got an anatomical or embryological explanation for this, but it's something I see day in, day out. And the key maintenance of the illusion of good symmetry here is the key is that her nipples are fairly symmetric. So if we contrast this to my failure here, the reason, even though I've done on paper a relatively similar operation, she's got laxer breasts and she's got much more significant asymmetry to the nipples. So that vertical nipple dystopia is really exacerbated. She got that laxity to that right breast, which is sitting lower, and the breast has almost got a form-fruste waterfall effect where the breast is slightly hanging off, whereas the left breast that had a slightly skyward pointing nipple has almost been lifted, even though we've used the same implants. So that's something just to be aware of. It's some of these subtleties that can be unpredictable and you sometimes only notice after the event. What about maintaining the folds? Well, you can maintain the folds frequently if they're not that asymmetric and persist with that illusion of good symmetry. Again, the nipples are very similar in their position. And I think that's quite a useful target to consider when you're making these decisions. And then it doesn't always work. And if you look at this patient, I've respected the folds. There's only a minor degree of fold asymmetry, but I think it's because her nipples are at different levels that it highlights the fold asymmetry or the breast footprint asymmetry. And there is always that compromise. And I think you have to take each patient on an individual basis, but I think nipple position is really key. And consider that patient wearing a t-shirt without a bra, and the better the nipple symmetry in that situation, the happier the patient. Or conversely, the unhappy patient is one whose nipples are very different levels. What about if you disregard the rules, if you don't respect them? Well, this is a patient we saw at the very beginning of the talk who I'd say has an iatrogenic double bubble. So she's 10 years post-op with submuscular breast augments, nanotextured implants. She's got an implant descent that progressed particularly over the last few years. No obvious instigating event. She's got a combination of double bubble, caudal malposition generally. And interesting, she has that memory, the native inframammary fold. And what you note when I expand this is if you look at my red mark lower down on the breast, that's where the scar was originally placed. So she had a possible F3 fold that was lowered and has suffered from further implant malposition. Now, this is really highlighted when you go into this patient and we're below the green line of the native fold. And you can see that once that is broken through, you can almost get down to the umbilicus. You can really have a plane of very little resistance. And if there's not a firm capsule formed, and we know that nanotextured implants form very, very little capsule, the risk is once they've started on that journey for malposition, they continue. So here you can see with the implant out, you can really see that where I estimated the original inframammary fold was going to be, it is exactly there. And you can see that the fold was lowered before and has had further expansion. So by taking all of this out and by restoring the native anatomy really, and making sure that the patient's original chest wall skin is back on her chest wall, we can restore a good breast shape. And here I'm going to talk about the breast net that you can see in this patient that I've used in the lower part of the breast later on in the talk. So she demonstrated, as you'll see in the next slide, actually post-op, you can see she had a very strong F3 and F3B fold post-op. So she was always a high risk for double bubble, and she's got a combination of iatrogenic double bubble and then further implant descent. So it would have been safer not to lower her. So here you can see an F3B fold, particularly on the left side when she raises her arms. So here she is with the implants removed, with a much more proportionate aesthetic breast and a much happier patient. And you can see the distance that everything has moved when you look at a fixed benign nevus on her chest wall. Another complex case of iatrogenic, almost double bubble on the right and bottoming out on the left. So a grade 3 inferior malposition on both sides. And here what you can see is again demonstration of the native fold. I've actually put a new incision in much higher up near the native fold. You might be able to see that there's the faint scar almost an inch below, if not more, of the original incision. But I felt I couldn't reconstruct her breast well without ignoring the old well-healed and mature scar and using new scars. So you can see that by respecting and restoring the anatomy before and after, you can see she's got a much more aesthetic breast with her native crease being back in the right place and a good, well-supported implant in the right position. So in summary, in terms of inframammary crease or fold planning decisions, examine the fold with your arms up or the patient's arms up and down. Consider whether there's a degree of breastosis, and a great tip for Maurizio Nava from Milan was always if the patient's arms are up and you cannot see their inframammary fold because of the ptosis, they definitely need a mastopexy. And I think that's a great tool, and it's a great patient education tool as well. If in doubt, be cautious lowering the fold, and if it's well established, do not lower the fold. And in certain cases, I think there's a very good role and indication for those low height anatomical implants if you can't lower the fold. And you have to really individualize and discuss with your patient the trade-offs if there's a significant fold asymmetry and how you establish this. So now onto the final part of what I'm going to talk about today, which is management of malposition with a special focus on the external pocket and external pocket control. Now, I've developed an algorithm for treating malposition, and it is busy, so I'm going to talk to you through the algorithm stage by stage. And the first question I ask the patient is, do they want to keep the implant? Which is a very obvious thing, but a key thing to ask. So if the patient does want to keep the implant, then we need to have a decision of how far after their original surgery are they and whether we can reuse the existing implant. And there's little data on this in the literature, but if that malposition has occurred within a few weeks, then I would use that same implant. Otherwise, I may consider a new implant. And then one of the key things is it volume redistribution alone that is required? I.e., is it purely malposition, but there's no other issue that you need to deal with that breast? And if it's yes, so the implant's sitting too high riding, too low, or it's too lateral, then you need to decide on what you're going to do with the capsule. Are you going to retain the capsule? Because if they've got malposition and capsular contracture, you're likely to remove the whole capsule. If you are able to keep the capsule, which is a very useful tool, then you can consider a whole raft of different interventions. capsular flaps, capsular orifices. You can use meshes in conjunction with the capsule. You can change plane and use neo pockets. If you can't keep the capsule because you're doing a capsulectomy, then you can try using internal control of that new implant with mesh or sutures. And then I will talk to you about how I add external control using the breast net, and we can consider changing the plane. If it's more than volume distribution alone that's required, then it's skin envelope adjustment too. And then you've got to consider that skin and soft tissue manipulation. Is it going to be a mastopexy? Is it going to be something without removing skin and redraping skin in a different way with a breast net? And if the patient does not want to keep the implant, then you have to remove the implant, make some capsule decisions appropriately, consider any adjunctive procedures, and address any double bubble or other issues, as we saw in the first patient example before. But I think the first decision to make, once the patient's going to keep the implant, is it more than just volume redistribution alone that's required? So if we break it down, step one is internal control measures to try and fix the malposition, and step two is external control measures to the breast and skin envelope. So internal pocket challenges that we face in implant malposition situations are typically an overly large pocket, potentially downsizing an implant. You're adding weight if you're upsizing the implant. You've got to contend with slopes of chest walls, the uncertainty of whether you can use a capsule if there is existing capsule. And you've got to bear in mind that every time we violate the integrity of the capsule, we're going to weaken the support any capsule could offer. And often these patients have suboptimal tissue quality because they're going to be older frequently than when they first had their implants put in. So there are different established options for internal approaches. We can use a variety of internal suture methods. The little video here shows a capsular hammock, a technique I really like and I learned from Steve Merton in Sydney, using capsular flaps, which can be incredibly useful, caudally, laterally, however they can be implemented. Capsular excision and different reefing or suturing methods inside. Popcorn capsular orifices have become a great tool, a very simple and effective tool. And then, of course, we might need to perform a capsulectomy, particularly in grade 3 and grade 4 capsular contracture. And don't forget that changing plane is often needed, whether that's making a neo pocket and keeping the existing capsule and walling it off, or starting again effectively. But sometimes these internal approaches aren't always enough. And we've got situations that patients may have some loose, thin, suboptimal skin top quality. There may be a sort of delamination and dissociation of movement of the skin that's separate from the deeper tissue. And whilst internal sutures and capsule work might support the implant position, they may not help externally, and it can be difficult to control that skin. And of course, if there's no capsule to use. So in normal circumstances, a mastopexy would be our go-to tool, and that is still what I would use in 95% of my patients. And that principle is of a mastopexy, in any form of mastopexy, typically a WISE pattern, would be to modify the skin envelope. Circumareola could be used for minor adjustments, but you've got to be aware of flattening the breast. I published in 2021 the lower pole mastopexy augmentation, a lower pole approach to mastopexy. And then there are what I could call freestyle approaches, doing whatever's needed, normally in the lower pole or lateral breast to hide the scars, to tighten and adjust any skin that's contributing to the morphology of that breast with an implant malposition. In any of these cases, I do think it's key to ensure adequate IMF support. And you want to minimize any lateral breast skin redundancy. And that can be difficult because that can be one of those difficult situations where you're worried that you're going to extend the scar so much that it's going to cause a problem. And this is the sort of problem we may encounter. So what if there is sort of mild to moderate skin excess? Can you justify a mastopexy? Would the patient want to accept or tolerate those scars? Might there be alternative approaches? And how do you deal with this if the patient says, I don't want any external visible scars? Well, if we look further afield and we look to Andre Auerswald's groundbreaking work with the hemostatic net in facial surgery, external percutaneous rows of quilting sutures to ensure the adherence of the facial flap, whilst the primary role was to reduce risk of hematoma, it's really become acknowledged as a fantastic tool to aid redraping of the skin. And that's been something we can apply to the breast. So the breast net, buttress reinforcement of external array of sutures that are placed transcutaneously, has really become a tool that I love to have in my back pocket now. So this was something we published in ASJ in 2022, and we applied the net to secondary breast implant surgery to redrape and position and stabilize the skin. And it did seem to be a lot more stable and secure than using internal sutures for some reason. It accounted for skin laxity, and we didn't have to excise extra skin. Now, I'm not for 1 minute saying this is a total replacement for a mastopexy, not at all, but it can get you out of jail. So the surgical approach is very simple and straightforward. Rows of over and over or freestyle sutures from external skin to deeper tissues of any type of deeper tissue, as many rows as required into whatever part of the footprint that's needed. Here you can see me putting it in and controlling the lateral breast in this case. Here she is a month later, typically using this large needle 4-hour ethelon. And here she is 8 months later in the same position. You can see it's an older patient, and you can see the stability of that lateral breast without that laxity. It provides excellent stability in any direction of the external footprint and redistributes the tension, not just keeps it in one area. So if we look at some patient examples, this is a 41-year-old patient with 22-year-old implants, differential implants. She wanted a similar size replacement. She's got a rupture on one side. Examining her, she's tall, slim, she's got terrible skin quality, she's got laxity, subglandular implants, large skin envelope, and malposition of L3 on each side and I2 on the right with a double bubble on the right. And this is someone with that degree of ptosis or pseudotosis who did not want what I recommended. She did not want the mastopexy. And this is a very difficult situation. She said, I'm prepared for any other intervention as long as I can't see any external scars. Now, the perceived challenge is the further laxity in the ptosis once the capsule is released as well, which could worsen the situation that she has experienced. So effectively, she's got this difficult situation that we would ordinarily routinely recommend a mastopexy for. And here she is on table, and you can really see the degree of laxity that she's got and that large pocket that she's got, expected with that lateralization on recumbency. And we can see the implant remove that very loose, big pocket with the sizing implant placed. You can see it's lateralized totally. And then I've done internal capsular flaps to help to medialize the implant. But unfortunately, what that's left us with is a significant degree of lateral laxity. And by placing the external to internal breast net sutures, I've really honed down and firmed up the footprint there. And afterwards, put her in an underwire bra and a micropore bra to help stabilize everything. And here she is with, I think, an acceptable, stable result, bearing in mind what could have happened. And I think what I'm so pleased about with this result is its stability. She's an out-of-town patient who sent me some photos from home sometime later. And again, it is something that has maintained some stability. Of course, time will tell with her tissue quality how long that lasts, but so far, so good. And we can look at further patient examples. I'm sensitive to time, so I'm going to go through some of these just to illustrate an older patient, downsized with significant downsizing who didn't want the scars of mastopexy. Another patient, older patient, 67, downsizing from 425 to 255 cc's, and a result that really doesn't suggest there's any skin laxity waterfall effect or any other issue with skin excess due to redraping the skin with the net. And then some challenging cases, a patient with a benign seroma on one side, she's 77, lacked definition in her cleavage inframammary crease area, and that's her desired goal. So by taking the implants out, seeing how lateralized that new implant would be without any stability and no capsule to keep it where we want it to, and using the net laterally and medially to stabilize things, what you can see is it really has defined the areas that were very important to her and has stood the test of time nearly a year later. And bear in mind, this patient's 77. She's had a reverse abdominoplasty prior to this as well. So this really has corrected the effaced anatomy. And I've applied this just for interest in several other situations where I've got skin laxity and skin excess, in this example of a benign seroma that I've removed with the implants and performed a mastopexy. She's been left with a skin fold or skin excess, and it was quite difficult to work out how to excise this without giving her too much visibility of scars. So by liposuction under local anesthetic aggressively, and then using the net to adhere that skin down, it's given her a good stable result without any new scars after the surgery. I'm going to actually skip forward on this next case example because of the interest of time, but there are many other applications that it can be used for to redrape skin. In this case, it was a post-weight loss gynecomastia patient, and it helped reposition the skin around the inframammary crease. I found it doesn't leave very much in the way of evidence. If you look very hard, you can see the scars. The other points are to use a large needle. I would do all the internal work and internal sutures first. The net placement, 3 to 5 days, and just make sure you've got that large needle to use it. And do educate your patients because it can be uncomfortable while it's in. So the net proves an excellent tool in our armamentarium. It's not a replacement for a mastopexy, but it's an adjunct. And it's particularly useful in poor quality skin in second surgery and can sometimes avoid those scars, but I'm using it more and more in non-implant cases. So let's just bring it all together for the final minute. I hope you've seen there is a usefulness in the classification system that we've described. I think analysis and classification are key as a first step to anything we do. It helps with communication and decision-making. Grade 1 malpositions, we're going to accept, and grade 3s warrant surgical intervention. Ideally, we'll prevent malposition by making good decisions regarding to the inframammary fold. We need to consider the weight of an implant and the body's ability and tissue quality to maintain it, and consider those adjunctive measures, and be cautious when we're using heavy, smooth implants. And then when we're managing implant malposition, we've got to think about the internal pocket versus the external envelope. Primary focus is internally, secondary is externally. Use mastopexy when you can and when the patient allows, but consider the breast net. And occasionally, such as in the patient in this illustration, we sometimes use both to really deal with extremely complex situations. So I'd like to thank you all for your time, and I hope this has been an interesting talk to listen to.
Thank you so much, Dr. Pacifico. That was a huge amount of information, wealth of knowledge. We so appreciate you being with us. Good stuff, really good stuff. So we've got a couple of questions that have been coming in directly and in the chat box. I'd like to welcome our incoming president of the Aesthetic Society, Dr. Tracy Pfeiffer, to unmute herself. She is going to kick us off with a question that she's got for you.
Wonderful talk. Thank you so much. Thanks for seeing everybody on the Zoom today. My question is, in the US, a lot of us don't use textured implants. I'm one of the rare ones who does. I think it's very useful for a lot of situations which you described. But how do you discuss with your patients the choice of implant device, whether it's going to be smooth or textured?
That's a great question, Tracy. Really good to see you here. It's a difficult one because there is no perfect implant. And I talk about the pros and cons. And I think it goes back to me talking about that I don't think any implant decision should be on a single issue. It shouldn't be purely on ALCL. It shouldn't purely be on malposition or capsular contracture. And I think it's up to us. At the end of the day, if we're honest, we can convince a patient to have the implant that we want to use, whatever that implant is, as plastic surgeons. But I think explaining the pros and cons and getting the patient to understand why we're recommending what we're recommending and what the trade-offs for that implant are going to be is absolutely key. And I think having a familiarity with using textured implants, which is interesting because when I go to the US, there's a sort of fear of textured implants. And when you talk in Europe, there's a fear of smooth implants. So it's this having some experience and using both as appropriate in one's practice is really key. But one of the things, particularly in those very established inframammary folds, where they're highly likely to cause problems if you lower them, if you're going to use a smooth implant, the risk is perhaps that they risk sitting too high and they don't do what you want them to do and cause that lower pulse stretch that you hope they will. And that's why in those situations, I really like the predictability of a textured implant, because I can really then be more confident of planning what I'm going to do. I hope that answers your question.
Thank you so much. All right, we've got a couple of questions on the net. The first one is from Morgan Martin, who's asking, how long does the net stay?
Yeah, I'm sorry. I thought I was going to cut my presentation. My presentation was too short. I could have gone on for a long time, I think. So the net, I take a view between 3 and 5 days, and that's depending on the patient's combination of things: their skin quality, their risk of visible scarring, because I have had 1 or 2 patients that I've noticed small dots from the net that they haven't. And of course, in darker skin, in Afro-Caribbean skin, you're going to have a higher risk of causing problems, or Asian skin. Versus this, again, coming back to trade-offs between how much support you're trying to offer. I have a number of patients I've left it in for a week, particularly older patients in their 60s and above with very loose, unsupportive skin. I'm not worried about scars. They're going to scar well, inevitably. And then I have that reassurance that that's really working almost as an external underwire bra.
Okay, and a related or adjacent question from Adriana Pascal is saying, what sutures are you using when you do the net?
Yeah, so I tend to use an ethylon, a nylon suture. I tend to use around a 4/0. The key is the needle size, because ideally, you can either put it in blindly, or you can put it in, as I showed in that video, under direct vision, where you're looking in the pocket, you're passing it from external, taking a bite internally and passing it back out. But and it should be easy. And what makes it difficult is when the suture length, the needle isn't big enough. That's the key. So whether you're using a 2/0, a 3/0, or a 4/0, what's more important is your needle size.
Okay. Dr. Barry Handler is asking, when you talked about textured implants, are you referring to polyurethane? Those of us in the US aren't familiar with those implants.
So in my personal practice, I don't use polyurethane. I tend to use microtextured implants. And that's I wouldn't discount using polyurethane implants if they were appropriate in individual cases. My concern, and this is not borne out by my experience with some polyurethane implants, is that in the cases such as the ones we talked about here, you've also often got very poor quality soft tissue and skin. And then I worry that their positioning and their grip is almost going to be too good, and you're going to get a high risk of a waterfall effect of that lax breast tissue falling over an implant that stays where you want it. So this is, again, you're kind of hedging things and wanting the implant to be as positionally stable as possible, but you also want a little bit of conformity with the breast over the years, particularly in the peri and postmenopausal breasts.
I'm going to tag on one of my own questions about the net. So obviously we hear a lot about it. There've been a bunch of studies published not only in ASJ but elsewhere. So you're talking about the hemostatic net redraping of the skin. Do you feel this is more well accepted because it kind of originated in Europe, or do you feel like even some of the plastic surgeons in the US who are not traditionally early adopters are, really starting to use it and it's picking up?
That's a great question. I think if we look at the literature and look at history, really, we've been using forms of the net in different areas in the past. So whether it's quilting skin grafts, whether it's using Pacifico sutures for vascular malformations, the concept of putting external quilting sutures in, it's been a brave thing for the first person to do. And I think Andre Auswald, I commend him incredibly for using it in the face, first of all. I think it is becoming more mainstream, it's more accepted. I think the early comments were about, oh, that looks bad. But a lot of the things we do in plastic surgery may initially look bad, but the end result is fine and it's worth it. So I don't think that doesn't hold water, that sort of comment. So I think the more widespread it is becoming, the more it's talked about, and whereas even 3 or 4 years ago, I think when you spoke about the net at a conference, whether it's to do with the face or elsewhere, people hadn't seen it before. Now people are familiar with it, and it's almost like, where can it go? What can it do? Where can it take us? And what are its limitations?
Yeah, I think, kind of at first blush, especially from a patient perspective, it is a little scary looking. I mean, it's very different than the sort of pre and post ops you see in facelifts. Next question here. So you talked about obviously grades 1, 2, and 3. So what would a grade 3 surgical candidate, patient look like? What would be perfect in terms of, they come in, they're a grade 3, they're going to need surgery. Give us some of the parameters of what would make them an ideal patient where you can really get a good result.
Well, it comes on, I think it primarily comes down to tissue quality at the end of the day. I mean, the ideal situation is you've got a patient and that if you can just put that implant back where it ought to be, everything else follows. And whether you've got to support the implant internally, My ideal situation is there is a soft capsule, but that soft capsule is strong enough to use as a capsular flap. As I said, I love the capsular hammock concept where you're dissecting the capsule off the chest wall, and you might need to do a capsulorrhaphy to release the capsule in the upper pole so the implant's got somewhere to head up. If you can do that, use that capsular flap, often that's all you need to do. You can just sew it up and you actually don't need anything else. You don't, in a lot of cases, you don't even need to resecure the incision in the inframammary fold back to the chest wall, although a lot of us will do that for belt and braces just to secure it. And then you've got the other extreme, the candidate that is either limiting your options, which is always a challenge for all of us, or the candidate that just has really poor quality tissue and it's got very thin, delicate tissue, particularly those patients with severely hyperplastic breasts that are very slim normally. They've just got a very mobile breast footprint. I mean, I think they're very difficult to get right. And that might be a great opportunity to use a polyurethane implant, perhaps, that maybe slightly younger, you're in that preventative situation.
So I'm going to pivot now to the poll that we're all hopefully still viewing. And you had asked us, after the classification of breast implant malposition has been discussed, do you now feel as an attendee of this webinar, this would be a pragmatic addition to your plastic surgery lexicon? Maybe not surprisingly, 88% have said yes. So I think that's a nice little bit of feedback on the education you're giving us here. Now let's see, we're going to take a question from Nathanya Pudya, who's asking, which case of malposition, in which case do you use radial score techniques?
Oh, well, the radial score is not something I tend to use with malposition. It's something I might use to try and, it's like a tuberous breast type situation when we're compelled to lower the crease in a situation in which there's a high risk of double bubble, and we know there is. So there are a couple of thoughts there. One is it's trying to anticipate and then prevent the double bubble. As I said in the talk, these are cases that I would always counsel my patients that it might be that secondary fat grafting needs to be accepted as a risk in that lower pole. But I have stopped doing it in the primary situation because by the time you've aggressively radially scored to try and really expand that, I don't know where you're going to put the fat, because my worry is it just sits there, it will become necrotic, it's not going to help them. So I do discuss that as at 2 stages. There is an argument, I know, and Gianluca Campiglio published, I think in the ASJ a year ago or so, an interesting fat transfer technique with a lot of subcision while he was addressing tuberous breasts, and really aggressively with multiple needle holes and pickle fork type approaches to really aggressively break down the inframammary, established inframammary fold to recreate it in a new place. But that, from memory, was a fat grafting rather than an implant-based technique he was describing.
Okay, that's helpful. Something I made a note of while you were speaking is I'm sure you're familiar with Dr. Caroline Glicksman and Dr. Pat McGuire. They do a lot of studies and research in BII and ALCL. So they have an article that'll be coming out soon in ASJ, and I guess they were kind of asked, you know, what they tell patients in terms of, you know, breast dogs and different surgical procedures. And they both individually, and obviously we know they're best friends, so they probably, you know, have a lot of the same thoughts, but they said, I don't promise twins, I promise sisters. So I'm not going to give you twins, I'm going to give you sisters. And I thought that was such a really concise way of explaining that, you know, breasts are different shape and size. And, you know, you're not really, just because you go to see a plastic surgeon, you're not necessarily coming out with, you know, 2 identical breasts. So my question to you based on that is, you know, what is your way of managing patient expectations in this regard, particularly when there's been a need for revision, malposition, et cetera?
Yeah, it's such an important thing. And I think one of the things we learn as we go on in our careers is how important that is. Because at the end of the day, as I say to my patients, the success of the procedure is actually you not thinking about it anymore, and certainly not thinking about me anymore. That's a success, as much as my ego may hate that. I think that's a true mark of a good outcome, is it's not an issue for that person's life. But I think the most important thing is, what we all know is that what the patient sees themselves when they look in the mirror is totally different to what is objectively there. And having a very open analysis of their anatomy and situation beforehand and reassuring them that it is normal to have differences. And I said, virtually every patient I've ever examined, their left breast crease is higher than their right. It's almost like a party trick in the consultation. I will tell them that I will predict your left breast crease is higher, and they'll not believe me. And I will show them, and then it becomes very apparent. And it's almost like a light bulb moment for them, which is very useful, because it then is something, oh, I never looked at that. Because the other thing I always tell them is that you're coming to see me about something that you're not totally happy with, so you probably don't study yourself much beforehand. But what I can guarantee is that after surgery, you will look a lot and you will notice things, and a lot of things you notice will have always been there. And it's important you know what those are before you embark on this journey.
I think that's brilliant, because oftentimes I think they, exactly like you say, they're not paying attention. They're focused on one particular thing in their nose, their, face, et cetera. And then, they might blame it on the surgery that, oh, now I look like this. But well, that's what the pre and the post-ops are for, to confirm that certain things were pre-existing, right?
And the other thing I think of is kind of in terms of predicting the potential satisfied or dissatisfied patient. And I talk to patients about this as well. Is if you imagine someone after surgery, if they're able to look back on their pre-surgery self and say, look where I was and look where I've come now, they're almost guaranteed to be happy, no matter how objectively good or not so good the result is. The patients who are almost guaranteed to be unhappy are the patients who have an unrealistic, idealized future self in their mind. And they're obviously, we all know, typically it's a rhinoplasty type patient who might have a celebrity's nose in their mind, but it can apply to every part of surgery we do. And I talked to them about that, and I said, you've really got to understand what your starting point is, and what we're working with is not, you're not looking at a catalog.
Yeah, that's a great pearl. So in our final minutes here, I have one more question. You talked a lot about scars, and obviously nobody wants a scar, but most procedures are going to, dictate that scars are going to happen. So, in terms of, as a plastic surgeon, predicting which patients, you can manage the scars best in, or that, maybe you'll take the case, maybe you won't, because they're coming to you saying, I don't want scars. There'll be scars, and, there'll be certain qualifications that, objectively won't work in their favor. So how do you deal with that?
Yeah, I mean, so a couple of aphorisms and comments I talk to patients about, because it comes, number one, down to trade-offs. You can't get from A to B without having to have the surgery, accept the risks of surgery, and have the necessary scars. One of the ways things I talk about for facial patients, for example, is I explained that in some facial cancer or reconstructive work, the scar will go all the way down from the corner of the eyebrow, down the side of the nose, down the side of the mouth, nasolabial fold, into the marionette lines. And that long scar on the middle of the face is sometimes very subtle and discreet and hard to see in the end. Whereas a short scar that crosses a nasolabial fold can sometimes jump out a mile when the person walks in the room. So it's not about scar length, it's about scar design, scar positioning, and other aspects that we have the expertise as plastic surgeons to determine. And the other final bit, I say, look, 80 to 90% of your future scar is going to be determined by your genetics. I can influence maybe 10 or 20%. Some people will just be bad scarers, and you have to recognize that.
And hopefully they've had some kind of a less major surgery before they've come to you to know that the keloid, they don't do well, whether it's in surgery or with scarring. So I think with all of the different advancements and innovations, we're evolving, and so are scars and some of the other the treatments. So with that, I'll just close with our next poll. We talked about the breast net. Can you envision using this? 75% are saying yes. 25 maybe, and no one said no. So I think once again, testimony to the research you're sharing and all of the ideas. And it's been an absolute pleasure having you with us. I look forward to seeing you on the road in the next meeting that we are both at, and have a really good rest of your day. Thanks to everyone for coming. We'll be back in August with the next ASA GEMS. And Dr. Pacifico, thank you.
Thank you, everyone. Thank you, Peter.